Thank you, Barb, and thank you for the invitation. So I'm going to focus on really on the clinical trialist sort of perspective. Once you have results from your sequencing center, how are you going to actually translate it into some sort of impact? We've heard a great talk from Roy. If you have lung cancer, we now know what to do. We'd call up Roy and ask him if we can enroll onto the lung map trial. And obviously, we obviously have many other cancers that we face, and how do we deal with that on a day-to-day basis? Here are my financial disclosures. Just to outline that I'm going to focus on challenges, which I hope to convince you there are opportunities really in the genomics era, on the technical aspects, clinical aspects, operational, and lastly, scientific. So I'm not going to focus too much on technical because in the morning we heard a lot of talks, and in the later part of this afternoon in terms of funding for these technical aspects of precision medicine. But clearly, to do this kind of exercise in our institutions, we need to have significant infrastructure, not just in terms of the technology, but obviously our ability to trust the results, the turnaround time, how much coverage do we need, the complexity of this data, and really able to translate it and make it realistic and make it functional, to understand how to use that data to apply to our patients. So really, what I'm going to be focused on is the later part of this, where we have the sequencing, we have the results, somebody hand us the report in the clinic. What do we do after that point? We've struggled with this, and in our own institution, we come up with a fairly simple annotation or classification scheme so that we understand as a simple clinician when our laboratory or our genomicists and our bioinformaticians hand us the result, we know a little bit more about the actionability of that finding. So we've done a fairly simple classification in terms of class 1 to 5, from 1 being a gene that is commonly, frequently recurrent in a gene and known to have a significant functional result, for example, BRAF V600 in melanoma, all the way to variants of unknown significance, where really we really don't want to report those findings because neither the clinician nor the patients really know how to handle those results. And eventually, I think in the years and days to come, we'll know a lot more to do what to do with these variants of unknown significance. Clearly, we're not the only ones thinking of that. There are many groups, and we've heard Mia's talk this morning, in terms of really how to put a value or a function to the outcomes that we have obtained from the sequencing. How actionable? Is it a driver or is it a passenger? And if it is a driver, how driver the value of the driver is, how significant it is in terms of linkage to approved agents, linkage to clinical trials, or is it more of a prognostic biomarker or a diagnostic biomarker? This is data presented from the Broad in a paper they just recently published in Nature Medicine, which I find quite interesting, where with the results that come out from their sequencing, they have tried to align it in terms of these particular classifications, again, to enable the clinician who is sitting in front of your patient to understand how best to interpret the result. I think a variant to a clinician means relatively little. To a patient, it almost means zero, and it is important for us to actually be able to use that information and make it work in terms of finding an action that comes after that point. So really focusing the talk on the clinical challenges, I think it's obvious that 5-6 years ago, we probably would not be having a talk like this because nobody knows what we're talking about in terms of sequencing in the clinic and applying it to the patient. So in order to keep up with this, I think it's highly daunting for clinical trialists and community oncologists and patients. And returning the results, I know we're going to have a session tomorrow. Pat's going to talk about this tomorrow and how to really be able to make it understandable to our patients, including the germline incidental findings that may come along. I think the focus that I want to focus on today really is how to actually find treatments for them. And if we decide to believe that matching matters, then to find drugs that are either approved in a clinical trial or even off-label use, if we use that word, to find something that hopefully we can capture the results and know whether this strategy is important in terms of precision medicine. And then translate it in a larger scale in our healthcare system to say that precision medicine makes a difference in terms of a strategy. So this is just really the report that we use in our institution, providing in terms of the sample quality, the variants that are found, providing some classification that I've shown you earlier on in terms of the scale that we use. And I wanted to tell you a few examples of institutions out there that have started doing this a few years ago and where they are at. So these are institutions across the world. This is Saphir-01, which is in France, Institute Gustave Roussy, where they have biopsy over 400 patients in breast cancer. And they try to profile the patients using genomic and transcriptomic technologies. And really, if you look at the numerator and the denominator as you filter down in terms of patients who have actionable mutations or very aberrations, and then finding treatments and ultimately that actually respond to that match, at the end of this, 13 out of 404 patients, 3% of patients had some benefit from this trial. And even if you just look at the matching, only a very small number of patients actually got matched to a trial. And the question is obviously why? Why can't we do better than this? Take another example. This is again from France. This was presented at AACR by, again, the French group in Gustave Roussy. This is a study more in advanced general cancer, the Moscato trial, where they have biopsy and profile 420 patients or screen 420 patients, biopsy 368, ultimately profiled 283 for various reasons. The samples may or may not be evaluable. They found that 38% of the original 420 were actionable, and at the end, only 20% were matched to trial. This is actually the highest number I've seen in this kind of exercise, which is obviously still fairly low. And how do you actually increase that number? In terms of actionability, we've heard Neil this morning, perhaps we should look at non-genomic aspects of the cancers, such as looking at their RNA, their proteins, and even epigenome, or even a non-coding genome. How can you increase the 20% that are matched to trials? Of course, you have more trials, more access to drugs. I think a lot of what we've heard about umbrellas and baskets are ways to actually increase opportunities for us to match these patients. And I think this is where we have to start thinking about, I think having a profiling program is important, and many institutions across the world have already got to that point. Taking the next step to translate it to benefit is much, much, much harder, really, to find treatments to actually show that what we're doing is relevant, is important to the care of the patients, is, I think, much, much higher a bar to reach. And I think this is where we should be focusing our time and energy, and I think this is why we're having our meeting today in terms of how to translate it into clinical relevance. So to give you an example of our own reports or our own report card so far, we've done similar strategy, except that we use archive specimen in our own impact trial. Compact is a sister program in our hospital where we profile across our province. They come to us for one assessment where we request a sample as well as a germline DNA sample to do molecular profiling using our current panel. And the top part is really our current waterfall plot, where we only really matching about 6% of our nearly 2,000 patients that have been enrolled into impact and compact. What happened to the other 94%? We've profiled them, we have their data. This is not energy that is wasted. We have a very rich repository of clinical data and genomic data that we are actively looking into sharing with other groups doing the same. But what I'm worried about is how come we do not have a higher percentage than 6%? And in groups that are out there similarly, the number is really ranging between 10 to 20% at the highest that I have seen. And how do we increase that kind of number? And obviously, if you look at just the efficacy end, I do think the waterfall plot is very promising. Below is a phase 1 trial of a phase 1 protocol from a PI3 kinase inhibitor where no specific prospective molecular selection was used. There was retrospective assessment of molecular genotypes, but one would argue that by doing this actively, you do have a fairly promising waterfall plot with the patients who are subsequently matched do have fairly significant benefit from the assessment. And obviously randomized trials such as the ones that Roy talked about would give us more definitive outcome. But I think the concern obviously from my aspect is how do we increase more matching? How do we find more treatments for these patients that make the whole translation relevant? So looking at our current portfolio, for example, at Princess Margaret, where in terms of our phase 1 study, at this present time, about 30% of our phase 1 trials require molecular selection. So these are not just your KRAS that you already have done. These are actually doing specific testing to look for that variant that is specifically asked for in the protocol to match them to a specific clinical agent. And you can see that this is really quite different from when I started about 15, 16 years ago. I would say almost no clinical trials in the phase 1 arena will look at molecular selection as an entry criteria. And I'm sure that number is going to only increase in the years to come. And we are actively developing strategy that trying to capture more patients. A lot of patients after their profiling cannot go on a trial because either their performance status has declined, you have no drugs for them, or they decided at that point they do not want to travel. We obviously trying to minimize all these barriers. We want to have more trials. We want to profile them as early as possible so that they're well enough to go on a clinical trial. And obviously, we want to have more trials. So in our own way, we created a spreadsheet to allow us to say, you have a patient with colon cancer, this particular mutation, these are the trials that they could go on, and we send this to our clinicians on a regular basis so that they constantly reminded that if you have a patient with this profile, you need to think about the clinical trial, you need to match them because this is how we translate our results. And we're going to need Mia's help to help us develop an app that actually can be generalizable to all across the country and others where this kind of strategy is being used so that clinicians don't forget to match their patients or to try and find treatments for their patients. So I think a lot of the operational challenges we've talked about this morning, because of the fact that we don't want to test serially, the whole multiplex is very important, panels are important, so that we have almost everything that we want done in one shot with one specimen. I think the nature of baskets and umbrellas are part of the whole process we have to evolve to. We want to be able to economically conduct trials that we can test a lot of patients under the auspice of one protocol. And I think baskets and umbrellas are a good way to allow us to do that, to actually physically and financially be able to sustain this kind of infrastructure. And what obviously is concerning as a clinical trial is that you might end up treating 1 or 2 patients in a big protocol, such as an umbrella or a basket trial, where the communication across sites will be germane so that you actually still understand the safety and the toxicity of the drugs by frequent communications, and obviously that will be done. And lastly, to look at how do we study combinations in this kind of framework. Traditionally, I think companies do not like to share with other companies, but I think that culture is changing. We already see that in baskets, umbrellas, where companies come together to be part of under the same umbrella or within the same basket to test their drugs at the same time. And I think combinations likely will be in the same kind of strategy. I'm not going to belabor the umbrella and the basket discussions. We've heard it to maximum today. I actually recently heard a new terminology, which is the tent discussion, where you put everybody, screen everybody in your institution and put them under the tent, and then subsequently under the tent you put them into umbrellas and baskets. I think we're very imaginative people in oncology. So these are just some of the umbrella trials that are being run. You've heard the lung map trial and the Alchemist trial in lung cancer, and obviously big cancer groups are thinking of that. And I think this kind of design lends itself to common histology. And ultimately, we need to think about the rarer tumors, what we're going to do with them, because not every tumor type can lend itself to an umbrella trial. So perhaps baskets is a way to go where you have tumor types with different histologies that have similar aberrations that can be lumped into the same basket and then assessed under the auspice of the same protocol. And the NCI match trial is a big basket. So Barb, who's here, who is leading the way, along with many investigators through the NCTN program, this is going to be an exciting trial that both US and Canada are going to be participating in. We're going to look at different aberrations with matching strategies where we will be able to understand a lot better in terms of whether this kind of matching will make a difference in their outcome. Again, setting a bar high to make sure that we really have meaningful outcome. Other trials that are international that are also baskets are listed here. Some of these are NCI, as mentioned. Some of these are companies that are already thinking that way. And I think locally we have also designed a lot of trials that are small baskets, again, thinking of the same idea. I know David in the back there has a lot of baskets and memorial as well. And similarly in Princess Margaret, we have our mobility series, which are small baskets looking at different molecular aberrations, either in specific tumor types that are lumped into the same basket or advanced solid cancers in general. And I think this whole idea of how to translate is not unique to what the clinician in the academic circles are thinking. Foundation medicine obviously is worried about that as well. They've profiled patients, they give them the result, so what next? So just a few days ago, this press release came out about them partnering with emerging medicine to find clinical trials to help their patients navigate so that they can as well translate the results to some sort of clinical outcome. So I think this kind of activity is going to be more rampant in the next few years. I'm going to just start closing a little bit by talking about some of the challenges, I think, even if we can find patients for our trials, to try trials for our patients to match them. I think something to think in mind that we do have scientific challenges in terms of precision medicine. I think traditionally we have been focusing on histology, and we've already heard that this is not enough. We do not want to throw our microscopes away. Our pathologists are still very important. We started thinking of really profiling one sample or one or two samples and finding treatments to match them. I think what we are concerned, obviously, is cancer is a very dynamic disease, and having just one aberration or one mutation that we profile and target is not going to be sufficient, because eventually cancers are going to evolve and change to avoid the treatment's effectiveness. So how do we design trials that are more dynamic, that can actually evolve as the cancers evolve? And this is really important in terms of the whole topic of tumor heterogeneity, both interpatient and intrapatient. So data presented by the MD Anderson group in ASCO this year, looking at the difference between primary and metastatic lesions. If you look at the common genes like KRAS, for example, it is fairly concordant, but some of the other mutations like PIK3CA, for example, there is a significant discordance between the tumor, between the primary as well as the metastatic disease. So obviously, if you had profiled only one sample, it's possible that you would actually not be catching what is actually active and relevant at the present time. And similarly, we've heard data from circulating DNA this morning that treatments can be seen in terms of emerging resistance, even in the circulation. For example, exposure to anti-EGFR antibodies in colorectal cancer, patients started developing KRAS mutations that you can detect fairly early on in their circulating DNA, that obviously we need to preempt this and perhaps use a strategy to combat this particular arising clone to make the treatment effective. And if you had not profiled and multiple samples or circulating samples, you probably would miss what could be at the present time the driver of the cancer. So I think this may be the next crop of trials that we need to start thinking about, is really a dynamic trial where we really be able to follow along the patients, perhaps biopsying them at baseline very thoroughly, not just genomics, but also transcriptomics, et cetera, RNA-seq, understand what the entire milieu in the cancer is like, follow them along, and sort of watch for what's happening in terms of the change in the cancer. At the time of progression, obviously, we need to know what has emerged. Again, do very deep interrogation and be able to really move along as the cancer moves along, to be really better understand the dynamics of the cancer and not just one specific static point in time. I would submit that likely in the next era, this will be an aspect that we need to focus upon in terms of matching patients to clinical trials. I'm going to end by saying that I think molecular characterization clearly to us is feasible and affordable, so we no longer have to worry about that as much other than the funding for it. The challenges I think lying ahead is that obviously we're going to be dealing with a lot of data. There's a lot of data overload in bioinformatic needs. How do we prioritize targets, not just in terms of their frequency, but more importantly, their functionality, their drivability, finding the drugs to match the genotypes, and then capturing that matching. How do we actually translate it into a value that would convince payers and funders that this is relevant and important? Will we ever be able to actually have the level of evidence that convinces them that it is? And designing the clinical trials that are not just a static time point, but a dynamic assessment of the cancer. And obviously, we all say that, but we all need to do it. We need to data share and learn. Thanks very much for your attention.
Thank you, Lilian. And then finally, we're going to hear from Anne-Marie Martin from GSK as to how they are moving forward with NGS in the whole pipeline of drug development.